distinguished chair and my dear friends. Thanks Kiran and Manikantan for having me, giving me the opportunity. I'm going to talk basically about the importance of atrial fibrillation and the use of non-vitamin K anticoagulants in the management of atrial fibrillation. All of us are aware that the atrial fibrillation is the commonest cardiac dysrhythmia. And we have a huge burden of atrial fibrillation in our country. We don't have the exact statistics, but it is believed that world over there could be more than 60 million with a daily disability adjusted years of 8 million per year. It's also believed that Indians may have around, if you calculate 1% of the population, that could be something like 14 million. So it's on the rise, and it creates a lot of havoc in patients who, if they develop a stroke. Atrial fibrillation always comes with an underlying risk factors and hypertension. These are the traditional risk factors: hypertension, obesity, smoking, underlying other structural heart disease. Earlier it was valvular heart disease. Now the contribution of valvular heart disease, rheumatic heart disease, in the genesis of atrial fibrillation is maybe less than 10% even in our country. Why this is not moving? Can you just move the slide? The slide is not moving. Can somebody come? You read something which blocked the movement. Next slide. Okay, right. Now just look at that. When someone develops an atrial fibrillation, you look at the heightened risk, heightened chances for somebody developing a stroke. And mind you, in atrial fibrillation, apart from all the other management, right management, other comorbidity management, the most important management part is stroke prevention. And that gives our unfortunate patient a 480% increased proclivity to development of a stroke. Just like the heart failure, now we have 4 pillars. Just like that, now the atrial fibrillation is now, especially this is the ploy by the European Heart Rhythm Society, and they suggest that you divide it into 2. Now assess the stroke risk, and then optimize the management, control the risk factors, and of course, you can think about the rhythm control or rate control. Today, we are not going to discuss any of those. We will be concentrating on assessing the risk and then managing with NOACS. And it's a tricky question to ask which NOAC. We have 3 NOAC available, or DOAC available now: dabigatran, apixaban, and rivaroxaban. So can you choose amongst these 3 for a particular patient? We will just see. So this is something I am sure all of you are aware of. When you have a patient with atrial fibrillation, do you assess his stroke risk and then decide on? Most of your patients, they'll be mostly in their 60s, they may have comorbidities, and when you assess the CHAS2-VASc score, if their score is more than 2, definitely they merit. Simultaneously, since we are going to use anticoagulants, not antiplatelets, there is no role for antiplatelet drug in atrial fibrillation for stroke prevention. You may have to use antiplatelet if they have an associated coronary artery disease. That we will discuss. But generally, for stroke prevention, there is absolutely no role for antiplatelet drugs. It's all anticoagulants drugs. So when you use an anticoagulant, it is natural that the patient may have a higher risk. And physician, we have to do a balancing act between the stroke risk and the bleeding risk. And that is where we have the challenges. Because the stroke risk and the bleeding risk go simultaneously, and most of the risk factors for these 2 are similar. Over the years, we have now a tremendous advancement in the availability of anticoagulants. Right now, we have, as I said, we have dabigatran, rivaroxaban, and apixaban. Edoxaban, we possibly will get in by next month. And so we have plenty of drugs to choose to, and we have strong data showing that these directly acting, I will prefer to call them rather than non-vitamin K NOACS, because they are directly acting. That gives you more thrust over the vasopressin. So these DOACs has a strong database over more than 100,000 patient data. And they have shown their superiority over warfarin through the very many trials. And they have also shown that there is substantial reduction in the intracranial bleeding, which is fatal. Many a time, intracranial bleedings are fatal. That's why now warfarin was now one of the most feared drugs to use to. So basically, DOACs has shown superiority, most of them, has over warfarin in stroke prevention and also in the bleeding. So we have, now I'm not here to go through all those trial data. Time will not permit me, and it is not needed. And we have the recommendation from all the relevant regulatory authorities saying that if you have atrial fibrillation, it is a class 1A indication for starting DOAC, the newer or the non-vitamin K directly acting oral anticoagulants over warfarin. Well, the problem is, I was mentioning you about which one, when you have three, it's rather difficult to pick and choose. There are unfortunately no direct comparison between these three agents. So you go through the meta-analysis, propensity, and all this. Tiny will be very much keen to tell you something about propensity analysis. I'm not here to tell you that. But there are very many. When you don't have a direct comparison, you get the statistical analysis and try to understand which among the three drugs are possibly safer, better. And so we have some data which says that bleeding. See, bleeding is something which is always concerning to the patient. We are more worried about the stroke. The patient is more worried about bleeding. So bleeding, if you take, now you could see that apixaban and to an extent dabigatran, but for his gastrointestinal excess bleeding, they are little safer than the other. Mind you, all anticoagulants can cause bleeding. And even the mortality reduction, you can see that dabigatran and apixaban has some, but then as I said, these are propensity analyses. Most important thing is give him an oral anticoagulant. Well, another question when you use a DOAC is whether you have to use the conventional, for example, dabigatran 150, 110 has been proven. Rivaroxaban, ideally 20 milligrams, whether you could see many people using 10 milligrams of rivaroxaban. We don't have too much of data, but we have some Asian data, Korea, Vietnam data, which shows that maybe 10 milligram in a high bleeding risk patient you can use. But conventionally, it is 20 milligrams daily. You may modify the dose as the renal function or liver function is deranged. Apixaban, we have mostly data with 5 milligram, but there is also some data with 2.5 milligram, which we use if the age is more than 80 or there is an altered creatinine clearance, or if the weight is less than 60, if the two among the three is there, then you can reduce the apixaban doses to 2.5 milligram. And we have some data. Not the large database, but some data showing that 2.5 milligram also reduces the stroke risk and it causes lesser bleeding. I will take a couple of minutes to tell you about the risk-based approach in selecting these three drugs. The CKD, we were mentioning about the importance of CKD. Jabir was mentioning about CKD being possibly a coronary equivalent. CKD patients mostly die of cardiovascular disease, be it CAD, heart failure, or atrial fibrillation. And you could see here, now, when the creatinine clearance is higher, possibly amongst these three drugs, I will possibly opt for an apixaban rather than the other drugs. Again, now we don't have too much of data in patients going on dialysis, end-stage renal disease. That's a tricky thing. People were arguing, why not give warfarin instead of the DOAC? If you are, but again, we have some data which shows that apixaban in smaller dose in dialyzed patients could be used. So this is the data. The dabigatran and rivaroxaban are contraindicated. Again, we don't have too much of data. Chronic liver disease patient, if you have an AF in a chronic liver disease patient setting, again, if in an advanced liver disease, none of the three agents can be used. But especially if you have something like a child pug scoring, I don't know much about this liver scoring disease, I should admit that. But if you have a mild to moderate liver disease, possibly again you can use apixaban or dabigatran. In elderly, again, atrial fibrillation is a disease of the elderly. So which drug to be used? Here again, possibly we have most of the data among the three on apixaban uses in many of these subsets. It is not because, as I said, we don't have a direct comparison among the three drugs. In an obese patient, again, if the weight is less than 60, you should be cautious enough to use apixaban in the full dose. But if otherwise, you can use the other two drugs. None of the DOACs can be used in pregnancy and lactation. This is another area where the physicians are again, how long? Somebody has undergone an angioplasty. He has atrial fibrillation. So you are supposed to use a dual antiplatelet, a DAPT plus a oral anticoagulant. Very tricky situation. So basically, if the bleeding is not very high, you continue the DAPT in a stented or ACS patient for triple therapy for 1 month. Then two drugs, preferably clopidogrel or with either apixaban or dabigatran or any of the drugs, any of the DOACs for 6 months to 1 year. And after 1 year, you just continue, skip the antiplatelet drug. Don't worry about the antiplatelet drug. Just continue the oral anticoagulant. And if the bleeding risk is very high, the triple therapy can be shortened to 1 week. Skip aspirin after 1 week and continue clopidogrel and DOAC for 6 months or 1 year, depending upon the HBR, the high bleeding risk, and then just continue the oral anticoagulant just 1 minute. If somebody develop a stroke, when will you give a NOAC? Now this is, all of you know about these 1 day, 3 day, 6 day rule, 1-3-6 rule. If it is and if it's an intracerebral hemorrhage, then you have to wait for almost a month to restart your oral anticoagulant. Somebody you have planned for surgery, again we have preferably, if the risk is high, you have to stop a DOAC at least 48 hours prior to the surgery. So we have to do a balancing act between its efficacy and the adverse events. If somebody bleeds on DOAC, there are reversal agents available, but don't worry about that. They are expensive, not available. Iduricimab is available for dabigatran, but andexanate, which is meant for rivaroxaban, apixaban, is not available, extremely costly. Just manage conservatively. You can use a prothrombin concentrate And here again, there are a lot of confusions about the use of even PCC, but manage them conservatively. Most of the time, unless it is an intracerebral bleed, they are self-limiting. So this is my last slide. So atrial fibrillation is a mortal disease. The mortality is something like a stroke plus AF patient, 1/3 die in 90 days. So it's a mortal disease, and physician has to use their clinical judgment. And among the three, DOACs, you have to use an anticoagulant. Better a DOAC than warfarin because of the innate problems of warfarin. And when you use a DOAC, you can try to choose among the three DOAC depending upon the other comorbidity. Thank you for the kind listening.
Sir, in a casualty, if a patient is having atrial fibrillation and patient coming with a stroke, and during MRI we found that there is a thrombotic. It has a thrombotic stroke. Whether we should add an antiplatelet with the anticoagulant, or we should continue with the anticoagulant alone?
Conventionally in strokes, basically you always combine antiplatelet drug. You don't use, there is not much of a role of a DAPT unlike an ACS in stroke. But conventionally, antiplatelets are start on day 1, and depending upon, you can apply the 1-3-6 rule, and if the AF is there, you can TIA start in 24 hours, if it's a minor stroke, start in 3 days, major stroke in 6 days. That is the convention wisdom.
If there is a major, the risk for bleeding is high, whether there is any change in the dosage of dabigatran?
But basically, the bleeding episodes are near similar. So I don't think there is any advantage. Of course, people have shown that if you use a smaller dose, bleeding is comparative, but it has never reached statistical significance.
Thank you.
So when there is a high bleeding tendency and renal impairment, we go for apixaban, better. So why this is not being used in persons with mechanical valve?
Basically, in mechanical, now we don't see too many. Fortunately, I think 80% is bioprosthetic or 90% is bioprosthetic, where you can use after 6 months. You can use DOACs in bioprosthetic valve. In mechanical prosthetic valve, 3 trials has shown no use, basically because they use the extrinsic pathway. Our DOACs only cater factor 10. While in mechanical valve, it is believed that factor 2 comes, factor 7 comes, factor 9 comes. So many factors comes, and warfarin seems to be a better choice.
Okay.
When we look efficacy, warfarin is a more powerful agent. Its advantage of the NOACS is safety, especially the 1/3 reduction in the intracranial hemorrhage, isn't it, sir? For efficacy-wise, if the thrombotic risk is quite high, like on a foreign surface, we have to inhibit, sir said, all the 4 factors. But now the situation may change. We are going to have the factor 11A inhibitor soon. So once the factor 11A inhibitor comes, now the studies are ongoing. Some of us are already the part of the trials. It is more safer than apixaban.
Absolutely. The one thing about the warfarin factor has to be clear. Now, if we can keep the INR in the therapeutic range. The problem with warfarin is its variability, its interaction with the food, drugs, and many a time the patient is not compliant. But if somebody on warfarin has keep the INR in the window period, 2.5 to 3, then there is no need for you to change over to NOAC, even though the intracerebral bleed is lesser. I do agree. Because after all, NOAC is a costlier agent than warfarin. We should also realize that. But since my topic is NOAC, I didn't spell much on warfarin.
No more questions?
Thank you.